Good evening, good morning, good afternoon. A very warm welcome to all of you to this ICH webinar dedicated to immunotherapy in lymphoma. And this is an update from the EHA, ASCO, but also Lugano congresses. I don't think I need to spend a lot of time highlighting that in recent years, immunotherapy has reshaped the whole treatment landscape across the lymphoma spectrum, from checkpoint inhibitors to CAR T cells, bispecific antibodies. The momentum continues to build with each major congress unveiling promising new data, evolving indications, but also emerging challenges. Today, we will take a deep dive into the latest highlights presented at these EHA, ASCO, and Lugano 2025 congresses, and we will discuss how these findings are redefining clinical practice and future directions in lymphoma care. And in order to achieve these goals, we are delighted and honored to welcome a top expert in this field, namely Dr. Remy Duleri, who will guide us through this exciting journey. Dr. Remy Duleri is a consultant hematologist at the Saint Antoine Hospital, Sorbonne University, but also he's currently a research scientist physician at the Dana-Farber Cancer Institute. He's also a subcommittee leader within the lymphoma working party of EBMT. He has published dozens of papers. Some seminal papers you may have seen recently is Nature Medicine paper about the risk of malignancies after CAR T cells. So, Remy, thank you for accepting our invitation. Thank you for joining us, and let's get started.
Hi, everyone. I would like to begin by thanking the IACH for inviting me to give this presentation. Today, I'll be giving you an overview of the latest advances in immunotherapy for lymphoma, based on data presented at the most recent international congresses, EBMT, ASCO, EHA, and Lugano. As always with this kind of summary, it comes with difficult choices. For the sake of time, I won't be able to cover all the excellent abstracts that were presented. I've selected key studies that I believe reflect important trends and innovations in the field. These are my disclosure. We'll start with aggressive B-cell non-Hodgkin lymphomas, where there is a lot to unpack, from novel combination to new constructs and frontline strategies. So fasten your seatbelt and let's dive in. On each slide, you'll find the abstract reference in the bottom right corner, including the first author, the number, and the meeting where it was last presented. The first study I would like to discuss was a study from the CTI working party of the EBMT, addressing a very important question about the outcomes of patient age over 70 years who receive CAR T cell, either T-cell or axi-cell. This is retrospective analysis with diffuse large B-cell lymphoma, and it includes patients from 2019 to 2024 from 15 European countries in 146 centers. Patients receiving lyso-cell were excluded. You can see here the main characteristics of the patient. Over 1,000 patients were included. So this is a very large cohort, And you see that about half of the patients, more than half, had a relapse or progression at the time of CAR T-cell infusion. Here you can see the toxicities. On the left side, you see the CRS, and at day 30, there were more CRS with axi-cell compared to T-cell, which is what's expected in this population and in the clinical trials that have been published. For ICANS of any grade, again, you have 48% of patients who had ICANS of any grade with axi-cell compared to 21% with T-cell. Now, in terms of non-relapse mortality, there was also a significantly higher non-relapse mortality with axi-cell of 10% compared to 6% with T-cell. Now, let's move on to the responses. Responses were much higher with axi-cell. The best response at day 100 was a complete response in 69% of patients with axi-cell compared to 49% with T-cell. It translated into an improved progression-free survival at 1 year of 51% with axi-cell compared to 37% with T-cell. And on the right, you can see the overall survival, which was significantly higher with axi-cell at 63% compared to 56%. Now, you can see that I think one of the most interesting findings of the study, you can see that there is no significant difference in terms of survival with regard with the age. If you look at patients who are aged 70 to 75 years or 75 to 80 or over 80 years old, there is no significant difference in terms of overall survival. What really matters for those patients is the ECOG performance status. You can see that patients who have an ECOG of 2 or more have a higher risk of non-relapse mortality and a decreased overall survival and progression-free survival. So to conclude with this study, axi-cell in this elderly population was associated with improved overall responses and progression-free survival, lower incidences of progressive refractory disease, higher rates of CRS and ICANS compared to T-cell, and the non-relapse mortality was higher with axi-cell compared to T-cell. Prophylaxis and management of early toxicities have improved in recent years, yet further strategies to reduce toxicity remain needed. ECOG performance status and also disease status at infusion were key determinants of outcomes in this elderly population. Let's move on to another study, again from the CTI working party of the BMT, but this time addressing the question of age in mantle cell lymphoma with a patient receiving breakthrough cell. So this is similar aims, except patients have mantle cell lymphoma. The study included 202 patients. You can see here the main characteristic of the patients. And here are the results. In terms of toxicity of, you can see first CRS of any grade, 83% of patients, but CRS of grade 3-4 occurred only in 9% of the patients. ICANS occurred in 56% of the patient for any grade of ICANS, and non-relapse mortality was, I think, relatively high at 16%. Now, again, important message. If you look at survival outcomes by age, there is no difference. If you go higher than 70 or higher than 75 years, there is no difference in terms of overall survival or progression-free survival. And in multivariable analysis, same message as I previously shown you in the previous studies, ECOG performance status is the most important predictor of survival. So to conclude, Brexucel is a promising option for elderly patients ineligible for intensive therapies. It induces remission in very high-risk patients, though longer follow-up is, I think, needed in this study. ECOG is associated with better overall survival and PFS when it's 0 or 1, regardless of age. Now, let's move to another study that focuses on the impact of comorbidities on non-relapse mortality with real-world evidence data from two centers, Gemelli in Roma and St. Louis in Paris. It included only patients with large B-cell lymphoma, and it tried to evaluate whether comorbidity burden affects toxicities and non-relapse mortality. The difficult question was how to grade comorbidities. So the study used three types of scores: CIRS, HTT-CI, and CVR4. The problem is none of those scores are designed specifically for CAR T-cell. Now, looking at the data, you have 379 patients included. And among those patients, depending on the score, the proportion of patients with comorbidities varies. So if you use CIRS, you have 15% of patients with comorbidities. With HTT-CI, it's 34%, and with CVR4, it's 7%. Now, regardless of the score you use, there was no significant impact of comorbidities on non-relapse mortality, as you can see on those curves. So to conclude, 7 to 34% of real-world CD19 CAR T-cell reception presents with high comorbidity burden. However, comorbidities do not significantly impact CRS, early or late cytopenia, the use of intensive interventions, or non-relapse mortality. So what's the implication of this study? Well, you can summarize it with frail is not fail. Frail patients should not routinely be excluded from access to CAR T therapy. Here is another study that I was lucky to present at Lugano, addressing the question of comparing CAR T to autologous transplant in the subset of patients who are in complete remission at the time of infusion of the therapy. It's a study I conducted with the Lymphoma Working Party of the EBMT. It's an important question because it's not because there is a new treatment that it is necessarily better or it should be used for everybody. And also, second question is that not everyone can access to CAR T nowadays. So both autologous and CAR T are effective in large BCL patients achieving complete remission after salvage therapy. However, it remains unclear which offers superior outcomes in this very particular population. And there is an CIBMTR study which reported higher PFS and lower relapse rates with autologous transplants compared to CAR T therapy. And it's, I think, warrants further investigation. So for this, we conducted a registry study comparing 2,521 autologous transplant recipients to 188 patients who received CAR T. You can see here the overall survival and progression-free survival, and there was no significant difference if you compare autologous to CAR T in patients in complete remission. There was a significantly higher relapse incidence with CAR T compared to autologous transplant, and no difference with regard with non-relapse mortality. With propensity score matching, with a multivariate Cox model, there was absolutely no significant difference between autologous and CAR T in terms of overall survival, progression-free survival, relapse incidence, and non-relapse mortality. So while I really think we need to work on offering a better access to CAR-T, I think those data show it's reasonable to consider or discuss the possibility of autologous transplant in this very specific population that is selected fit for transplant. Now, let's move on to another important study from the Lymphoma Working Party, BMT, and GoCAR-T consortium, which addressed the question of relapse patterns and treatments of patients receiving CD19 CAR-T cell. So it's again a retrospective multicenter study which included patients with large B-cell lymphoma, 325 patients who relapsed after CAR-T were included in the study, with the majority of patients who received axi-cel. You can see here on the left, the overall survival after CAR-T is very low, with a median of only 6 months. But the timing of relapse is critical. It really impacts the outcomes. If the relapse occurs within 2 months, the overall survival is only 10%. If relapse occurs after 6 months, the overall survival is 48%. Now, focusing only on patients who received allogeneic transplant after CAR T-cell relapse, you can see that patients can achieve a much better overall survival and progression-free survival if they are in complete or partial remission versus no response. Patients who achieve complete or partial remission before going to allogeneic transplants have an overall survival of over 50%, which I think makes you consider this option when you achieve this response. And you can see that obviously the relapse incidence was much higher if there is no response, which explains why the survival is much lower. Now, I've shown you a few studies showing that you can expand CAR-T for older patients, for patients with comorbidities. But I've also shown you that after relapse, the outcomes are very poor, except for a subset of patients who reaches complete remission or partial remission. We need to improve the outcomes. And for that, I think there are different levers. One is to optimize current therapies. The other one is to innovate with next generation constructs. So to optimize current therapy, you can combine CAR-T or bispecific antibodies with synergistic agents, or incorporate bispecific antibodies into frontline treatment strategies. If you want next generation construct, you can either develop dual targeted CAR-T cell, explore novel antigen targets beyond CD19 and CD20, design next generation constructs secreting cytokines or engager molecules, or leverage alternative immune effectors such as NK cell. Well, the good news is that all those options are addressed in the following abstracts I'm going to present. I'm going to start with this study presented at EHA that combine lysocell with NKTR255, which is an IL-15 receptor agonist that prolongs interleukin-15 half-life and induces durable activation of NK cell and CD8 positive T cell. You can see here the results of this study. So it's a very small cohort, but I think the results are very promising. The overall response rate was 83%, with a complete response rate of 83%. So very high response. And 5 of the 13 subjects who achieved the partial response at first restaging later converted to complete remission. Oh, excellent results, and it was consistently high responses compared to pivotal and real-world data. Also, it translated into durable complete remission with PFS was not reached at median for patients who achieved a complete remission, but also for the overall cohort, the median PFS was not reached. At 12 months, the median PFS was 59%, and it was 82% in patients who achieved a complete remission. So to conclude, it was well tolerated. Only 9% experienced CRS of ICANS after NKTR-255. This combination led to durable responses. And also, importantly, CAR T-cell re-expanded following NKTR-255 infusion. There was actually a higher CAR T-cell expansion with NKTR-255 compared to Lysocell alone. And well, I think it's very preliminary, but it supports further evaluation. Let's move on to another study that combined Lysocell to acalabrutinib for relapsed refractory large B-cell lymphoma. The design was to start with acalabrutinib, then there was apheresis, and then restart of acalabrutinib, then the infusion of Lysocell, and acalabrutinib was resumed at day 14. It included adults large B-cell lymphoma that were relapsed or refractory, and it was powered to evaluate the complete response rates. You can see here the characteristics of the patient, and most patients were refractory. And here are the response to Lysocell. So after acalabrutinib and then Lysocell, we had 93% of the patients that were in overall response, with 81% of the patient in complete response, and a median duration of response of 19 months. And here on the right side of the slide, after a median follow-up of only 10 months, you can see a very promising progression-free survival. So acalabrutinib plus Lysocell demonstrated promising efficacy in relapsed refractory large B-cell lymphoma. This combination was well tolerated with no unexpected toxicities. And I think this finding provides additional support for the combination of acalabrutinib or other BTK inhibitors with CAR T-cell therapy to enhance treatment efficacy. Ongoing and future studies will address long-term outcomes and explore correlative biomarkers to better understand the mechanism driving clinical benefits. Now, after improving current therapies with CAR T, I think very exciting abstract focused on using bispecific antibodies at frontline. So this is the first study using bispecific antibody at frontline that I'm going to present. It uses epcoritamab for patients over 75 years. It's the EPCOR DLBCL-3 study. You can see here the inclusion criteria of this phase 2 study. And there was two arms comparing epcoritamab alone and the other one epcoritamab plus lenalidomide. But I'm going to focus here on the results on the arm with epcoritamab alone. Here you can see the results in terms of efficacy. There was a high complete response and high MRD negativity rates. The complete response rates was 70%. And you can see that it went across all subgroups of patients, depending on age, Ann Arbor stage, IPI, or bulky disease. In terms of toxicity, there was a favorable safety profile consistent with previous reports. CRS were manageable and predictable in terms of timing. ICANS were mostly low-grade and resolved in all cases. Epcoritamab monotherapy achieved high response rates, as I have shown you. And, well, I think it could be an option for this frail population, older population that could not be eligible for anthracycline, for instance. So to conclude, epcoritamab offers a promising chemotherapy-free option for elderly large B-cell lymphoma patients with comorbidities ineligible for standard chemotherapy. There was another exciting study which combined rituximab, polatuzumab, and glofitamab for unfit elderly or frail patients with large B-cell lymphoma. I think it was one of the most exciting studies. It was first presented at EHA and then at Lugano with more details. It was a one-arm multi-strategic phase 2 study with an initial cohort of 80 patients. You can see here very impressive overall response rates of 92.5% with complete metabolic rates of 81%. Very impressive results in terms of responses at frontline, and safety profile was very manageable, what you can expect with those drugs, even if it was used at frontline. So to summarize, I think this chemotherapy light association of treatment, combination of treatment shows outstanding responses rates and a manageable safety profile, supporting further clinical evaluation as a first-line treatment option for elderly, frail, or medically unfit patients with aggressive lymphoma. There was another study that uses immunotherapy at frontline, presented by the LISA. It combined tafasitamab, lenalidomide, and rituximab. I think it's also an interesting approach in this elderly population. However, the response rates were not as good. You can see here that the complete metabolic rate was 49%. And also, the safety profile was maybe not as good as what I've shown you with the two previous studies with specific antibodies. This chemo-free combination of tafasitamab, lenalidomide, and rituximab in frontline for DLBCL patients aged over 80 years allowed an overall metabolic response rate of 72%. Well, in this highly comorbid population, adverse events were frequent despite a dose-adaptive approach. This regimen did not compromise subsequent arm mini-CHOP as salvage therapy, and I'm looking forward to see results in terms of quality of life. I think the strong point of this study is that it uses drugs that are currently commercially available and that you can use in this very old population. Other studies uses a bispecific antibody in frontline, this time in high-risk DLBCL with IPI from 2 to 5. It combined epcoritamab with R-CHOP. This is very preliminary results from 46 patients, but you can see that there was an overall response rate of 100%. 91% of patients achieved complete remission, and with a quite reasonable follow-up of 23 months, you can see a very promising progression-free survival on the right side of the slide. For the overall cohort, it was 82% at 2 years of progression-free survival, so very good results. And the safety profile was quite manageable. So to conclude on this study, we can say that this combination is associated with high response rates, encouraging PFS, manageable safety profile, and it suggests that adding epcoritamab to R-CHOP may improve frontline outcomes in high-risk patients. However, it needs confirmation in randomized studies, which, for the good news, I can say that it has already started. There is a phase 3 EPCORE DLBCL2 trial that is ongoing with efficacy results expected within the next year. Another combination, this time not for the front line, but for patient of relapse. It's a combination of epcoritamab with rituximab and ICE in 31 patients. Again, very high response rates in this refractory population. Most patients had complete remission and could proceed to autologous transplant. I'm going to move on to another combination, very similar. This time it's glofitamab compared to rituximab and ICE in relapsed refractory DLBCL. It's the iMatrix GLOW trial, and it shows similar good results. And I think it's going to be maybe a standard of care in patients who did not previously received bispecific antibodies. Again, another association that combines glofitamab to GMOX, and it's a study that was randomized and that compared glofitamab GMOX to R-GMOX. It was already published in Lancet in 2024, and we're lucky to see at Lugano an update of the follow-up. With the longer follow-up, you can see that the progression-free survival is still much better with glofitamab GMOX compared to R-GMOX at the median of 14 months compared to 4 months. So again, it confirms that there is a real benefit of glofi GMOX, and also this benefit is seen in overall survival. There was also clinically meaningful overall survival benefits in patients who were treated in second line. And the glofi GMOX safety profile is unchanged compared to the primary analysis and is consistent with the non-risk of the individual study drugs. Another, I think, very interesting combination is glofitamab with loncastuximab tesirine, directed at CD20 and directed at the same time at CD19 with lonca. It's the LOTIS-7 trial. You can see here in this population of 41 patients that it was a favorable safety profile with very low rates of high-grade CRS, only 5% of grade 3 CRS, and only 5% of grade 2 ICANS and no grade 3 ICANS. Here are the responsive. It was a very high response rates with a complete response rate of almost 87%, promising durability of response, though I think longer follow-up is needed to confirm outcomes. But these early data support further investigation of this chemotherapy-free anti-CD20, CD19 combination of bispecific antibody and antibody drug conjugated. Now, here I'm going to show you a few new constructs that comes with exciting results for patients with large B-cell lymphoma. So one of the new constructs that was presented at EHA is a dual CAR of CD19, CD20 that was presented by EHA. It's the KITE 363. Here you can see preliminary results. It's only a limited cohort of 23 patients. You can see that the overall response rate was very high at 87% in this very refractory population. And the complete response rate was 78%. This bisystronic CD19, CD20 targeting CAR T-cell therapy showed also favorable safety profile in this phase 1 study with no dose-limiting toxicities. There was no CRS above grade 2. It was only grade 1 and grade 2, which is very encouraging. There was 2 grade 3 ICANS cases of short duration, no grade 4 ICANS. And in this, the CAR naive, highly refractory large B-cell population, those level 3 showed an overall response rate of 87%, a complete response rate of 78%, and the median duration of complete response is not yet reached. Also, interestingly, there was a dose-dependent expansion observed. At dose level 3, there was a 3 to 5-fold higher expansion of CAR-T compared to axi-cell. Well, it is still preliminary, but I think the results supports KITE 363 as a promising therapy for refractory large B-cell lymphoma, and maybe also it could be applied for other diseases such as autoimmune disease, something to consider, I think. It's not the only dual CAR that was presented, so I'm going to move on quickly. There was also the J9J4496 that was presented in a very similar population of large B-cell lymphoma refractory, and most of them were naive of CAR-T. You can see here low rates of CRS and low rates of ICANS. There was only 8% of patients who had grade C ICANS and only 4% of patients who had grade 3 CRS, no grade 4 for these CAR-specific toxicities. Here are the responses. The overall response rate was 96%, so excellent results, with a complete response rate of 77%. And finally, third dual CD19, CD20 directed CAR was presented again in Lugano. It's called Zamto cell. So very small differences, I think, in terms of constructs. Here, the difference with this abstract, it was specifically for patients who has CNS involvement of the disease. And I think there is an unmet clinical need for those patients. So I'm very excited to see that there is a development of a new construct. Also, the strong point of the construct is that there is a very short vein-to-vein time of only 12 to 14 days. Here is the efficacy, also very encouraging. In the CNS lymphoma, the overall cohort, there was an overall response rate of 85% with a complete response rate of 64%. And toxicity, again, was similar to what I've presented in the two other abstracts, very manageable. I'm done with the part on aggressive non-Hodgkin lymphoma. Let's move on to the exciting result presented for indolent and mantle cell non-Hodgkin lymphoma. I will start with the ELARA study presented by Catherine Thieblemont. So it's not a new study, but it was interesting to see a longer follow-up. It uses TISA cell for follicular lymphoma who are in relapse or who are refractory. Here you can see a much longer follow-up. So that's why the study, I think, is very interesting. There is a plateau and a 48 months progression-free survival of 50%, very high responses. There was a high response rate reported at any time after infusion of 69%. And high-risk features did not significantly impact complete response rates, progression-free survival, or overall survival. And finally, I think also very encouraging data is that there was a very high MRD negativity rate in this study presented. So a confirmation that it is a good option for follicular lymphoma who are in relapse or refractory. Now, there was some innovation presented with this combination of tafasitamab, lenalidomide, and rituximab, which was compared in the inMIND phase 3 study to lenalidomide rituximab, again, in follicular lymphoma. So lenalidomide rituximab is a standard of care, and it's interesting to see if there is a benefit to add tafasitamab. Here are the data. Well, the trial met its primary endpoint, demonstrating that adding tafasitamab to lenalidomide and rituximab significantly improved PFS. Well, you can see here on the left that the median PFS was 22 months with tafasitamab compared to 14 months in the control group. The safety profile was manageable, consistent with known toxicities of each agent. This is the first study to validate the combination of anti-CD19 and anti-20 antibodies for follicular lymphoma. And I think the strong point is that this regimen is feasible both in community and academic settings. There was also innovation with the use of frontline bispecific antibody for follicular lymphoma with mosunetuzumab in the Morning Sun phase 2 study. I think one of the most exciting and important abstract presented for follicular lymphoma. So the study included previously untreated high tumor burden follicular lymphoma per GELF criteria. 102 patients were included, and you can see here the efficacy results. The response rates by subgroup were quite consistent. Even in high-risk subgroups, was high response rates. The overall metabolic response rate was 87%, with a complete metabolic response of almost 61%. Here is the PFS presented. The follow-up is still short, only 1 year, but you can see a very nice plateau and a PFS at 83%. So very, very promising results. And finally, the safety profile here showed that it was quite manageable, what you can expect when you use mosunetuzumab for this patient. So to conclude, the fixed duration subcutaneous mosun showed promising efficacy in previously untreated high-risk, high tumor burden follicular lymphoma. Safety profile was manageable with most injection site reactions, CRS, and infection being low-grade. CRS incidence was consistent with prior data in relapsed refractory follicular lymphoma. I think the findings support further evaluation of mosun in frontline, particularly in outpatient community settings. Another exciting abstract showed that you may soon be able to use CAR-T for MZL lymphoma. So marginal zone lymphoma is most of the time responsive to first line, but unfortunately some of them are refractory. And it was the purpose of one of the subgroup of the Transcend study using lysocell, and you can see here the design of the study shows that first the safety profile is very manageable. There was only low rates of CRS and neurological events, only 33% of neurological events, and not many patients had high grades, only 4%. And here is the overall response rate and complete response rate per CT assessment. You can see here that the complete response rate was 62% with an overall response rate of almost 96%. So lysocell induced deep and durable responses in patients with relapsed refractory marginal zone lymphoma who received at least 3 lines of treatment, a very favorable safety profile, and I think it could be a new standard of care in this population. Now let's move on to Hodgkin lymphoma. So there are to select abstract. I will only mostly focus on this study who received the Van Beckum Award at the EBMT. It's the Lumin ICE 203, which combine allo-NK to innate cell engager. So allo-NK is a non-genetically modified allogenic cord blood derived off-the-shelf cryopreserved NK cell products, which has a high surface receptor expression of CD16A. It is combined with a a C-termic. A C-termic is a tetravalent bispecific antibody construct, which selectively binds to CD16 on NK cells and to CD30 on Hodgkin lymphoma cells. And a C-termic directs the cytotoxic activity of NK cell toward the lymphoma cells. And also the combination synergistically improves lymphoma cell killing via ADCC. You can see the design of the study, which included Hodgkin lymphoma patients with a total of 22 patients included. They were all Hodgkin lymphoma who were pretreated with chemotherapy, brentuximab, checkpoint inhibitor, and had exhausted standard of care therapy option. 59% of patients had also received prior stem cell transplants. The results are promising with an overall response rate of 86% and a complete response rate of 55%. You can see also that this therapy induced an increase in the mean levels of interleukin-15, which can also participate to the good results seen in this study. Finally, let's talk about T-cell lymphoma. Well, there is definitely an unmet clinical need in patients who are refractory to frontline therapy, and so far there is no commercial CAR-T or bispecific antibody. And here are two abstracts that use anti-CD7 CAR-T cell. So it's still preliminary. It's the first study uses autologous CAR-T cell. It's a Chinese study that included only 10 patients. But I think there is a promising efficacy in relapsed refractory T-cell lymphoma with an overall response rate of 100% and a complete response rate of 90%. The safety profile was favorable with only grade 1, 2 CRS and ICANS and transient cytopenias and infection. CAR T-cell persisted after the infusion. However, you can see here on the right that we still need to improve the progression-free survival. So it's a good result in terms of responses, but I think there is no durable responses. The other study used allogenic CAR-T, so it was to evaluate the safety and efficacy of CD7 CAR-T cell after allogeneic transplants. And they used the same donor for allogeneic transplant that for the CAR-T. 16 out of 17 patients included in the study achieved a complete remission. But after a median follow-up of 8 months, only 6 patients were still alive. The main cause of death were disease progression and infection. I think, yeah, it's encouraging data, still not convincing enough in terms of durability of the response. Now, I would like to give you some key takeaways. I've presented a lot of abstracts. I would like to summarize it. First, older or frail patients can benefit from CAR-T and bispecific antibodies. Frail is not fail. Patients age over 70 years or patients who are frail should not be routinely excluded from immunotherapy. ECOG and disease status are key predictors of outcomes. Bispecific antibodies are now moving into frontline therapy for unfit patients ineligible for anthracycline and for high-risk large B-cell lymphoma or follicular lymphoma subtypes. The third good news is that we now have promising results of combination therapy with CAR-T or bispecific antibodies, and I would like to highlight the very promising results of rituximab, pola-glofitamab, or glofitamab lonca, but also the combination of liso-cel with acalabrutinib or IL-15 receptor agonists. We are excited to see the development of next-generation constructs. A lot of dual CAR are coming, targeting CD19 and CD20, and we see preliminary results of CAR with new targets, so that's CD7 or CD70. However, longer follow-up, quality of life assessment, and confirmatory randomized trials are needed for most studies to fully define patient benefits. With that, I would like to thank you for your attention. I hope you enjoyed this presentation, and I'm available if you have any questions.
Thank you very much, Remy, for really an amazing and comprehensive overview. I have enjoyed it a lot personally and learned a lot. The field is really moving rapidly. So we have time for some questions. And one first question that I've seen in the chat is about immunotherapy for CNS lymphoma. Where do we stand? What about CAR T cells? What about the bispecifics? How do they fit in the CNS lymphoma landscape?
Well, it's a very good question. I think this is a high-risk population with poor outcomes. The good news is that now we have, I think, enough data to say that it is safe to give CAR T or even bispecific antibodies to those patients. We have mostly data with CAR T that have been published, some of them from the Lymphoma Working Party of the EMT. And as I've shown you in this presentation, it's now even considered to use dual CAR targeting both CD19 and CD20. So yes, I think to summarize, in patients who relapse after frontline therapy, you should consider CAR T, I think, as the main option for those patients.
Wonderful, thank you. Another question, you alluded to dual CAR T cell, and the comment we have from the audience is that unfortunately they are not available routinely, and it's only clinical trials. So how can we today optimize the use of the classical CAR T cells, the commercially available CAR T cells we have? Do you recommend maintenance therapy? Do you recommend, I have several questions, so I'm just throwing the questions. Maintenance therapies after CAR T cells. Do you recommend the bridging with bispecifics or bispecific consolidation or maintenance after CAR T cells?
A lot of good questions. I don't think I have all the answer because we're still doing studies for that. So yes, in my presentation, I tried to start with what is available and also to show you what's coming next. Fortunately, dual CAR are not ready yet for commercial use. I think now we have more and more data to improve the outcomes. So one way to improve it is a better selection of the patient. I started my talk to show you that you can give to patients that are older, but maybe you need to select patients in terms of their ECOG performance status. Patients who are not fit and have a very high ECOG maybe should not go to CAR T. So that's one way to improve better selection. But the other way to improve the outcomes might be to combine it with other drugs. And I've shown you that combining with BTK inhibitor is a promising option that is available. You can use it in some patients. Now, what about maintenance? I have not seen convincing data yet, so I will not recommend using maintenance therapy. And I think one of the important questions was bispecific antibodies before, after CAR T. So right now, it's not commercially available. You cannot use bispecific before the CAR T unless you are advanced and it's the third line or after that. I would not recommend bispecific antibody as a bridging therapy. I think you should go to CAR T when it's possible to do it. And know that bispecific antibody can be used as for patient who relapse. So I would not use it as a maintenance. I don't think we have data to support it, but now we have more and more data showing that in the event of a relapse, it's very efficient. One question that might need to be refined and is to for this very small subset of patients who are in partial remission. So they have incomplete remission. They are not progressive at day 100. And I think some of them might have good outcomes, but I think a subset of those patients are at higher risk of relapse. And maybe for them, you could discuss using this specific antibody. But for now, it's not recommended.
Excellent, thank you. We have a question. Can you comment about the subgroup of patients who may still benefit from auto transplant instead of CAR T cells?
Yes, I'm very happy to talk about that. I've been lucky to conduct this study and have it accepted at Lugano for presentation. So it's a study that talks about, I would say, the real life. It's something that happens. You're planning to do a treatment for relapse, and sometimes with bridging therapy, there is a complete remission. And what is the best option? So the study I've shown you is that in both cases, if you use CAR-T or autologous transplant, in both cases, you have very high PFS. It's more than 80%. So it's very good option in both scenario. I think one limitation of the study is not intention to treat. So it's a selection of patients. It's a study that includes only patients who are eligible for autologous transplants, not all patients. So we cannot conclude that both are the same. I'm just saying that in a center who do not have access to CAR-T, it's still a good option to give autologous transplants. And I'm trying to address the question, is the only standard of care CAR-T? I think the answer is no. CAR-T is probably the best option in this situation. And if you have CAR-T, go for CAR-T. But if you don't have CAR-T, don't stay, I'm sorry, I'm not giving you the best option. It's still a very good option.
One last question before concluding. What is the role of allogeneic stem cell transplant following failure of CAR T cells?
Oh, it's a very good question. I think we are gathering more and more data, and there are more and more cases showing that we should not forget about allogeneic transplants. I think after the first CAR infusion, people were very excited, and with good responses, there was no need to do allogeneic transplants. Unfortunately, most patients still relapse after CAR-T. So I've presented data on 300 patients who relapsed, and I've shown you that in the event of a response to the salvage therapy after CAR-T, if the patient is in partial response or complete response, you can expect an overall survival of more than 50% with allogeneic transplant. So it's not for any patient, because if you do CAR-T at the age of 75 or 80 years, maybe is not fit for allogeneic transplant. But in the subset of patients who is fit for allogeneic transplant, I think you should consider allogeneic transplant after salvage therapy with, for instance, bispecific antibody.
Thank you very much, Remy, for sharing your knowledge, your experience, and for the time you spent on summarizing all of these recent data. I think we've seen throughout this webinar that immunotherapy continues to redefine treatment landscape in lymphoma, with exciting advances presented at EHA, ASCO, and Lugano, from novel bispecific antibodies to CAR-T refinements and checkpoint inhibitor strategies. The momentum is, I would say, unmistakable. These innovations not only expand our therapeutic arsenal, but also challenge us to refine patient selection, optimize sequencing, and maybe anticipate resistance, actually. So at the ICH, we remain committed to bringing you timely, independent, and practice-relevant insights. Thank you for joining us, and we look forward to continuing the conversation as the field evolves. Take care.